All right. Well, I'm going to just get us moving and welcome everybody to Trauma Training Tuesday. And our topic today is birth trauma. Um, in the sort of prepping of this, I really was thinking about how much many people, the birth of their child is like the most important moment of their life. Like, without exception, in every country around the world, it's one of the top things that people say was like a life peak, highlight of their life. So people go into this with incredibly high expectations, and the importance of it in individual lives cannot be underestimated. It's huge. And so that kind of thinking, in social work, we really look at individual experience, but also the bigger pictures of it. We have this incredibly intensely important individual experience that's impacted by these social forces like hospital closures. And we know and we anticipate and we've heard from people that their life will be changed if they don't have the access they need to the services they need. And when they have what they need, their life is dramatically changed for the better, right? When things go as planned, it's beautiful. I'm so grateful to have Chloe Schwartz here today from the March of Dimes. And this is what the March of Dimes does. They really look at this from a health equity, a health access point of view, specifically maternal child health. And Chloe is the director of maternal and infant health initiatives for March of Dimes for Massachusetts. She's responsible for designing and implementing the market's mission strategic plan, which includes programmatic and advocacy agendas. She has a master's in public health from Tufts and a BA in psychology from Boston University, my alma mater as well. While working on the MPH, she designed and completed a research project with the Center for Reproductive Rights under the U.S. Maternal Health Rights Initiative. This project provided a strategy as to how birthing hospitals in New York City could better communicate patients' rights before and during childbirth. Chloe previously worked as an account exec at the Boston office of Cerconi Brown, a national PR firm. She began her career at Kell and Partners as an account coordinator. So she really has this sort of breadth of understanding public relations and the importance of people knowing and understanding what the environment is, as well as specifically zeroing in on maternal child health. And so again, if you're not speaking, we'll ask you to mute. We're recording. We're expecting people to jump on in. My dear Kelsey Hopkins will be monitoring the chat, and I will be sharing Chloe's beautiful slides. Look at that. Looks good, right? All right. And I think I will probably mute myself, Chloe, and then I'll just take my cues from you on where to advance. And we know that we have an audience that has expertise and interest as well. So we're definitely want to make space for that. And just thank you so much, Chloe, for being here as we experience an impending crisis of access to maternal and child health here in the #1 state for this, Massachusetts. We are not immune. I'll zip it and turn it over to you.
Thank you so much, Amy. Thank you for having me today. It's great to meet and see all of you virtually. I'm really excited to be here today to share this latest report from March of Dimes titled Where You Live Matters, Maternity Care Deserts and the Crisis of Access and Equity. This report is an extension of our existing maternity care deserts report, which we release every other year to really drill down into some more details within each state, DC and Puerto Rico, to really take a look at what is going on across the US within, physical, logistical access to maternity care. So we go to the next slide. Perfect. So before we go any further, I'll just take another quick minute to introduce myself. I'm Chloe Schwartz, Massachusetts Director of Maternal and Infant Health for March of Dimes. I am a lifelong Massachusetts resident. I went to undergrad and grad school in Boston. I've been with March of Dimes for 2.5 years. And I absolutely love what I do, especially first and foremost, because it means I get to connect with groups such as this one. This is my favorite part of my job. Sometimes the topics are a little heavy, but they're incredibly important. And the folks that I meet working on this day to day are, I think, the best kinds of people out there. And so I'm just grateful every time I get to meet with a new group. Go to the next slide, please. We can go to the one after that as well. So we can kick things off with a quick discussion on what a maternity care desert is. It is a very prevalent term today, but it wasn't a few years ago. And so just in case there are some folks still getting up to speed with what it exactly means, we know that maternity care encompasses healthcare services for women during pregnancy, during delivery, and postpartum care. So the official definition of a maternity care desert is any county in which access to maternity healthcare services is either limited or absent completely, whether that's through lack of services open and available, or there are barriers to a woman's ability to access that care within those counties. Any county in the US without a hospital or a birth center that offers obstetric care, or a county without any practicing obstetric providers, would be a full and complete maternity care desert. Access to quality maternal care is a critical component of what March of Dimes is trying to do, and is more important each and every day, particularly when we look at additional data that examines how families are faring in this 21st century that we are in, and unfortunately does not bode well for a lot of our communities. We can go to the next slide. So March of Dimes began releasing comprehensive reports on maternity care deserts in 2018 and has continued to do so every 2 years. This year, we went off schedule and we delved even further into the data to look at several other important factors that impact access to maternity care. I'll also just quickly call attention to the fact that this data only goes up until 2020. Unfortunately, in the US, certain state and national data categories are significantly on a lag. So while we can get preterm birth data for the year before, data such as this is not readily available in a short-term manner. So just so everyone is aware, all of this data goes up until 2020. It's our hope that this data will be used to inform policy and practice recommendations in each state to prevent further decreases in access to care. These reports represent some of the largest body of research of its kind on the state of maternity care in the country, and are really unique in their comprehensiveness. And so I'm excited to be able to share this with all of you. We can go to the next slide. Great. So nationwide, our latest report showed that as of 2020, more than 5.6 million women and birthing persons are living in counties with no or limited access to maternity care services, forcing families to find new ways to get the care that they need. 2.2 million of those individuals live in counties with absolutely zero maternity care services. From 2019 to 2020, there was a 4% reduction in birthing hospitals available. And from 2018 to 2020, the US had more than 300 birth unit closures. Hospitals in nearly 1 in 10 counties across the US have lost obstetric services since 2018, adding to an overall decrease in maternity care access. This would be unacceptable in any circumstances, but it's particularly alarming when we think about how mothers and birthing persons today are 50% more likely to die in childbirth than their own mothers were. And that is the statistic that really hit home for me. I had a colleague phrase it that way. I knew that data painted that picture, but to hear it so concisely and concentrated in that way really hit home. 50%
Can you say that again?
Yeah. Mothers and birthing persons today are 50% more likely to die in childbirth than their own mothers were 1 generation ago. So in 2020, approximately 900 women across the country died of causes related to pregnancy, with a 14.2% increase in deaths from the previous year, and more than a 30% increase since 2018. And we now know that the CDC is reporting more than 80% of these deaths as preventable. And so improving the maternity care landscape is of the utmost importance to March of Dimes and to many of our partners across the country. So with those harrowing statistics, we can go to the next slide. Families face too many obstacles already. Getting the care they need shouldn't be this difficult. It's as simple as that. Working to improve access to quality and consistent maternity care by bringing awareness to maternity care deserts is one way in which March of Dimes strives to reduce preventable maternal mortality and morbidity for all pregnant people and improve the chances for the best possible start for every newborn. We can go to the next slide. All right, so let's get into this latest report. These 52 supplemental reports that examine all 50 states, DC, and Puerto Rico examined new factors that impact access to maternity care. So these reports include an examination on the geographic distance between homes and OB providers and facilities at the time of birth, a sub-analysis on the effects of poverty, housing cost, and racial segregation on adequacy of prenatal care, a map of Title V family planning services availability, an analysis of chronic health conditions in association with birth outcomes. And we finished the report with policy and practice recommendations to improve access to care and the current status of them in each location. So if we go to the next slide, we can look at some highlights. So we have some of the major highlights for the state of Massachusetts as of 2020, which officially declares the state free from maternity care deserts as they are defined broadly. With that said, we also found that nearly 5% of all women and birthing persons in the state had no birthing hospital within 30 minutes driving distance based on normal traffic patterns, and that nearly 10% are receiving inadequate prenatal care. Overall, on average, there is a low vulnerability to adverse outcomes due to the availability of reproductive healthcare services. However, finally, women and birthing persons with chronic health conditions are 47% more likely to experience preterm birth than women and birthing persons with no chronic health conditions. So in the next few slides, we'll dive into each of these data points in a little bit more detail to really paint that picture. Perfect. So while we may not have officially had any defined maternity care deserts in 2020, we did see between 2019 and 2020 a 3% decline in the availability of birthing hospitals in just 1 year alone. And we've seen from the headlines more closures since then. Half of 1% of all babies, so that's approximately 345 births in the state, were born to families that live in rural counties. And we've thrown the definition for rural just in there. And so our biannual maternity care deserts report really focuses on this. What I'm excited to go into is the next few slides, which paint a bigger picture as to what is really going on in each state. So we can go to the next slide. This one I think is particularly interesting and requires some nuance to really think about. So the farther a woman travels to receive maternity care, the greater the risk of maternal morbidity and adverse infant health outcomes, stillbirth, NICU admissions, things like that. Longer travel distances to care can cause financial strain on families. They can increase prenatal stress and anxiety. And the distance a woman must travel to access care becomes a critical factor during pregnancy, at the time of birth, and in the case of emergencies. Nationwide closures of birthing hospitals have contributed to increased distance and travel time to care, especially in rural areas. So mapping software was utilized to calculate distance in both miles and minutes under normal traffic conditions, using real-world travel routes. So the map indicates the average distance to the closest birthing hospital throughout Massachusetts. Commonly used thresholds of 30 to 60 minutes driving time were applied to measure the percent of birthing people with timely access to care. And so this information can help identify areas where resources are needed to improve access to care in a physical sense. So overall in the US, women and birthing persons are traveling 9.7 miles to their nearest birthing hospital. So key findings for Massachusetts: include traveling an average of 6.9 miles and 13.8 minutes to their nearest birthing hospital. Those who are living in counties with the highest travel time, so those top 20% highest travel times, were traveling up to 12 miles to 20.6 minutes on average to reach their nearest birthing hospital. However, what I do want to call attention to is the phrase under normal traffic patterns for two reasons. One, this travel time was only able to be conducted for car travel, so it doesn't account for public transportation. And it is based on low to no traffic. As someone who's lived here their whole life, I think it is fair to say normal traffic patterns are few and far between in a lot of areas of Massachusetts. If you live in Provincetown and need to get down to the hospital on a Sunday afternoon in the summer, or you're trying to get into the city from Revere with the Sumner Tunnel closure, chances are you might not make it. And you've had to stress and think about what you're going to do the week that you're due. Are you going to get a hotel somewhere closer? Are you going to risk it? How much stress and anxiety is that going to cause? We know living here that we have constant disruptions with both tourism and road work in this state, in addition to normal rush hours and traffic disruptions. So I just want to call attention to that as well, that, we can take this and definitely see areas that need more attention. But with that said, we can see from the Cape it's already in the highest category, and we know it's worse than that as well.
Just wanted to add that as they had the hearing about the closure in Leominster, people called attention to how many families don't have a car and don't have access. There's not public transportation there, and women are riding bikes to services. And oh my gosh, right? They don't even have, if you don't have a car, I don't know what on earth you're going to be able to do in this situation.
Mm-hmm. Absolutely. So on this slide, we focus on access to family planning services. And family planning services allows for people to achieve goals around having children, including the timing of and spacing between pregnancies. An unexpected pregnancy or too little time between pregnancies can lead to adverse health outcomes, including preterm birth, depression, anxiety, and more. Providing access to affordable contraceptives is a strategy to help people attain their family planning goals. So Title V clinics are federally funded healthcare sites that provide low-cost reproductive healthcare services, including contraceptives, as well as wellness exams and breast and cervical cancer screenings. The map displays Title V locations and areas where women and birthing persons are vulnerable to poor outcomes due to lack of access. County level risk data is derived from Sergo's U.S. Maternal Vulnerability Index, and a darker color indicates greater vulnerability. Overall, families in Massachusetts have a low vulnerability to adverse outcomes due to the availability of reproductive health care services. Unfortunately, we haven't seen much of a trend of closures of these types of services compared to other services. So within this one category, we can at least say things are okay. In addition, early and regular prenatal care is an important strategy for reducing risk of pregnancy complications and adverse birth outcomes. Historically, women and birthing persons of color have had lower rates of adequate prenatal care and may be less likely to receive services such as important health screenings and appropriate monitoring of the baby's growth and development. Socioeconomic determinants, including poverty, social support, education, create barriers to care that can worsen the disparity in prenatal care usage. The Maternal Vulnerability Index defines areas where women and birthing persons are vulnerable to poor outcomes due to these socioeconomic determinants. And the impact of these determinants on prenatal care usage was assessed by examining the percentage of women and birthing persons receiving inadequate prenatal care in areas with higher versus lower vulnerability. Inadequate prenatal care, we define as having either no prenatal care at all, or having care that began during or after the 5th month of pregnancy, as well as it included less than half of the appropriate number of visits for the infant's gestational age. in Massachusetts, 9.7% of women and birthing persons are still receiving inadequate prenatal care, compared to just under 15% for the US overall. However, one thing to point out, if you'll look at this chart, is that Black families in Massachusetts are continuing to receive inadequate prenatal care at a rate greater than all other families, regardless of whether or not they live in a higher or lower vulnerability area, at more than 15, 16%. So that's above the national average. And so when we think about how well Massachusetts is doing, we're still really failing a lot of our families. And we can go to the next slide. This is also, I think, a really interesting part of the report to share for our state. Having chronic health conditions before pregnancy increases the risk of pregnancy and postpartum complications. Preterm birth, which is a delivery before 37 weeks gestation, is just one example of a complication that can lead to serious health impacts. It's something that March of Dimes has worked on for decades. The burden of chronic health conditions among birthing people is increasing across the US. Access to healthcare before, during, and after pregnancy is even more important for appropriate managing of these chronic health conditions. At the time of birth, women and birthing persons with chronic conditions in their babies may need access to higher level care, such as specialized providers, hospitals with the ability to perform a cesarean section, hospitals with a neonatal ICU, and other services. And so examining the chronic health burden across Massachusetts and its relationship to adverse outcomes provides information needed to make important changes that can result in targeted resource allocation, prevention, and appropriate disease management. So the percent of birthing people with one or more chronic conditions was calculated for each county. The following conditions were included due to their availability within a birth record. So that includes pre-pregnancy hypertension and diabetes, smoking, being underweight, or being classified as obese before pregnancy. The map describes the county level chronic health burden in relation to the preterm birth rate. So areas shaded in purple will have both a high chronic health burden, greater than the overall state average, and a high rate of preterm birth compared to the national target of 9.4%. In Massachusetts, the preterm birth rate in 2022 or 2021 was 9%, compared to 10.5% in the US overall. And 31.5% of women and birthing persons had one or more chronic health conditions, compared to 37.8% in the US overall. So we're faring better, but not by a ton. Women and birthing persons with one or more chronic health conditions have a 47% increased likelihood of having a preterm birth compared to those without any chronic health conditions. One chronic health burden is associated with a preterm birth rate in Massachusetts of 10.5%, which is on par with the national average. Two or more chronic health burdens is associated with a preterm birth rate of nearly 16%. That's extremely high. And so we see two counties in Massachusetts with a high burden of chronic health conditions and a high rate of preterm birth, both Berkshire and Hampton. Hampton County has the highest preterm birth rate in the state. I believe it was just around 10.5, 10.6%, so around the national average. And I will say also the last report that we released on preterm birth data, that 10.5% national average was the worst preterm birth rate we've seen since we started releasing these reports more than a decade ago. So with that said, we can go to the next slide. Great. So March of Dimes has long supported policies that improve access to maternity care, including Medicaid expansion and extension, improving the integration of the midwifery model of care, reimbursement for doula care, and increasing the availability of telehealth services across a range of healthcare specialties. Telehealth is healthcare delivered using technology to replace or enhance in-person care. And so to address the limited access to maternity care in the US, states have to adopt and support telehealth. and other innovative practices to expand access and provide more options for healthcare delivery. The current state of telehealth policies and innovative solutions in Massachusetts aimed at improving maternal health outcomes is also explored in this report. And by highlighting innovative solutions implemented across states, policymakers and healthcare professionals can identify other policies and programs that can improve health for pregnant people in Massachusetts and ensure that they're receiving the support and care that they need. Fortunately for our state, Massachusetts has already passed laws to permanently provide Medicaid telehealth coverage for maternity care services and provide Medicaid reimbursement of the following telehealth services: live video, remote patient monitoring, and audio-only services. Massachusetts also provides full Medicaid coverage for non-citizen pregnant persons, including undocumented immigrants, with incomes at or below 200% of the federal poverty level without a 5-year waiting period. We are considered a leading state in addressing postpartum mental health services for women and birthing persons through screening, referral, and treatment. The state reimburses for 1 prenatal and 1 postpartum depression screening, and the state recommends and reimburses for maternal depression screenings during well-child visits up to 6 months of age. We can go to the next slide. With that said, from our current status compared to what we just reviewed for 2020, I want to bring attention to these headlines that you might have seen just in 2023 alone. So we cannot forget that the healthcare landscape is always changing across all facets. And these trends we're seeing do not bode well for our community's futures. It's not unique to maternity care services, although that's where March of Dimes' focus is, but we're seeing closures in pediatrics, in urgent cares, in primary cares, elderly care, and more. And every time one of those closes, the demand to another location increases and takes away time and resources from those existing patients. The demand and the burden on each healthcare system is growing every single day. And so I just wanted to take a moment to acknowledge that while we look at all of this data, and it's incredibly important, we're living in real time, and we need to also be able to identify ways to bring awareness to that. And so one more slide to land on a hopefully more hopeful note. What can we do? There's a lot to do. There are groups such as this one bringing folks together to raise awareness, have these important conversations. Transparency is key here. Right now in Massachusetts, the legislature has numerous policies in place, that they're reviewing, having hearings for to help improve maternal and infant healthcare access across the state. March of Dimes actively advocates for many of these on both the federal and the state level. I am our state registered lobbyist. I do all of our state level advocacy work. I am at all of these hearings testifying in favor of these bills. And I would strongly encourage anyone who is interested in pursuing, advocacy to join us in this fight to improve the health of all moms and babies locally. So if you scan this QR code, you can join our statewide grassroots network. It'll keep you updated on key policy priorities for us, opportunities to testify, our annual volunteer lobby day, and more. I promise you, it is not spammy. I am the one who sends out these alerts, and I very much minimize them to important key opportunities. Our annual lobby day, which we call March for Change, is a great opportunity to learn about advocacy. This past March, we had more than 30 volunteers join us for meetings on Beacon Hill. For most of them, it was their very first time. I love that. I think it's a really great almost orientation to advocacy. It's low pressure. It's just an opportunity for folks to share their story, whether it's personal or professional. So some of the key policy priorities that we're working on right now, if any of them are of interest to you, please don't hesitate to reach out. I will drop my email on the chat after this. The Moms Matter Act, we are on the Mind the Gap Coalition in Massachusetts to advocate for that. That would create 2 new grant opportunities for community-based organizations to grow and diversify the perinatal mental health workforce, because we're seeing huge need for more mental health services for pregnant and postpartum families. We're working on a bill to guarantee coverage of postpartum depression screenings at pediatrician visits up to 1 year postpartum. We're working to ensure Medicaid coverage for doula services. We're working to guarantee 3 days paid leave for pregnancy loss, including miscarriage, failed adoption, failed surrogacy match, and embryo loss. It's very comprehensive of all families. We're working to increase access to postpartum home visiting services and more. That's just, some of the key priorities we're working on right now. But I would love to connect with any of you interested in this work. I think it's hugely important. I think not enough of the everyday workers and families' voices are heard. And so that is my hope also in doing these presentations, is to find more voices for our policymakers to hear from. And so with that said, that is all that I have for you. I would love to take your questions. Again, I'll drop my email in the chat, and I hope you found this report informative.
That was so helpful, Chloe. Thank you so much. I definitely hadn't thought so much, and I'm struck by how much populations that already have a chronic health condition are really impacted, right? And we know about disparities that people, and I love that you had some, racial breakouts, but if people don't have access to support for any of their conditions, it's going to contribute to the overall burden. Those are some really striking statistics. And feel free to jump in. Anybody who had, saw some question in oh, they're having trouble. Okay, there's a group of people joining us from one location, so that's exciting. And I know, I don't know if people put things in the chat to everybody. Oh, there's a question in the chat. Do women typically call ambulances in situations where they can't drive? Do ambulances take longer time to respond to women in labor, similar to how they take longer to respond to overdoses, because their priority goes to issues like heart attacks and stroke? I don't know if
that's a great question. To my knowledge, I'm not entirely sure. I know this report didn't really examine ambulances versus personal automobiles, but I would love to go back to our research team with that question, because I think that's a really important point. So yeah, I will take that back to our research team.
I know that we had somebody at the hearing that spoke to, he was from Lunenburg, and they had 2 ambulances in Lunenburg and one was down for like repairs or whatever. So he was really speaking to, that happens. Those are the kinds of things that happen. And what is that going to mean when you're making choices about where to send your ambulance to the person who might be having a heart attack, or the person who, these are pretty dramatic life and death outcomes that aren't being managed at the level that they really need to be managed at, and looked at. And again, so grateful that March of Dimes is really looking at this from a comprehensive lens. Go ahead, Lisa, jump on in.
Hi, my name is Lisa Field. Nice to see you, Chloe. Nice to see everybody. So I'm with the Mass Nurses Association. I live in Taunton, which is an epicenter of a big closure and the aftermath. So I just want to touch base about the ambulances. So we found it very difficult. I'd say it's been 5 or 6 years since our local hospital closed maternity. And it's been very difficult to try to find out in real life factual terms the impact of, 1, ambulance response, but then 2, how many births have happened in the ambulance. So what we've had is, we're a gateway community. Many women previously had walked over to the hospital in order to get both prenatal care as well as deliver their babies. Women continue to do that, walk in, and then the hospital calls the ambulance to kind of ship them out to another place that has OBGYN. We went from 4 OBGYN practitioners here in the city down to 1. There's only 1 that does OBGYN. So that exasperated the whole access to care. The OBGYNs, there are 3 remaining. The 3 previous one dropped the OB and just kept it to GYN. So we know we had a greater, what we call the maternal health roundtable, where we call the stakeholders together. This is pre-COVID, to try to find out. We knew from WIC that about 25% of the women who were receiving WIC benefits, WIC couldn't account for where they were receiving any prenatal care. But it's been hard to quantify that, you know what I mean, to try to pull people together to find out, how do you do that? How do you get extra prenatal care in the city? How do you get where there's a bus route? That was another thing, that there was no bus route that went from, in our case, instead of delivering at Morton, women were supposed to go to, or birthing were supposed to go over to Good Sam. There's no direct bus route to that. That's not the way people go. So people kind of went all over the place. Is the deal. We know for a fact that within the first 6 months, there were 4 babies born in the Home Depot parking lot off of Route 24 and 106. And we only know that because the local firefighters and police put it on their website and Facebook page saying, hey, look, we delivered babies. And everybody was like, how wonderful. No, not wonderful. That was an indication of what the issues are. So trying to find data, I just kind of want to highlight that to Chloe, has been we've had state legislators, you know, contact DPH says, you know, it's an essential service, then it's done, the service ends, there's no follow-up. Where do the patients go? What's the impact on the remaining hospitals that have OBGYN? And again, last point, and then I'll shut up, I promise. But when they had the essential services hearing in Taunton, the hospital had said, well, you know, women can go to Sturdy and Attleboro, or they could go to Toby and Wareham, or they could go to the 2 hospitals in Brockton. Well, a year later, Toby closed. Then at that essential services hearing, then the Toby folks were saying, well, they can go to St. Luke's, or they can go to Falmouth, or they can go to BID Plymouth. Well, guess what? A year later, Falmouth closed. Then at Falmouth, they said, well, they could go to Cape Cod or in Hyannis, or they could go to BID Plymouth. And it gets smaller and smaller. And then in turn, what happens is that those hospitals that are left with OBGYN are busting at the seams. I mean, you name it, there's not enough staff, there's not enough actual beds, there's not enough actual supplies. And then, you know, my last issue is what I'd say is that, you know, these hospitals say, well, we had to close because it only averages 1 birth a day. Well, you know, babies don't call up the chief financial officer and say, is it my turn to be born? It doesn't average out that way. And those are for the actual healthy pregnancies with a live birth. That's not all of the miscarriages and all of that. So I know, like you said in the beginning, that your data stops at, you know, kind of like 2020, and the aftermath, it's going to be really interesting to see the data in a couple of years, because we're just getting started, because you've had Morton, Falmouth, Toby, Norwood, and then on top of Norwood, the Brockton fire. That's just Southeastern Mass. That's not going anywhere else. It's just Southeastern Mass.
Thank you so much for that. That was really informative, and I hear you. I've heard about those closures happening one right after the other, but it's really interesting to hear within the context of one closing being referred to another one, and then a year later that one's closed. I think that's really devastating that the Home Depot births are being highlighted as anything positive. Yeah, gosh, wow, just thank you so much for sharing that.
Go ahead, Sandy. I know you can speak to some of the policies and the advocacy, and right in the DPH for Leominster, we got the report back, and it was like, you need to do this, you need to do that, but we kind of recognize that they don't necessarily have any authority, that really we can show them all the stats in the world, but the hospital can really just do whatever they want.
So that's really what I kind of want to get to. But first, Amy, please. I want to thank you for bringing Chloe to us and bringing this conversation for us all together. We've watched this now for many, many years. Chloe outlined it. Lisa, you'll see a few of us from M&A, from Mass Nurses, are here because, you know, we're the canaries. Tara is actually a frontline maternity nurse. Lisa and I are both community organizers at M&A, working with the nurses who are doing the frontline work. We're usually the canaries down there in the shaft, right? That we'll get word. We're hearing the rumblings. We're seeing the hospital's practices leading to their self-fulfilling prophecy. that birth rates are down. Birth rates are not down in the area. Birth rates are down in your facility because you've quite intentionally funneled those patients to other places so that you could report this data at the end and say, well, see, we only have one patient a day. I mean, I could go on and on and on about those examples. The fact of the matter is right now we are at this juncture that I just see this promise. I see a community, certainly in our state. We know that this is a national problem. I was just having breakfast with my niece, who is an adolescent pediatrician in Milwaukee, Wisconsin. And they have just suffered the same exact closures all around the outskirts of Milwaukee. And she's an adolescent pediatrician. So her patients are becoming pregnant birthing mothers. And now there's no place. So this impact and this ripple has just gone on and on. And I value so much that we put quantitative facts to what we've been seeing anecdotally for decades, Chloe. So, we as an organization have seen it. We as an organization have been filing legislation, have been working on community work, have been lobbying legislators to change the policies. And we're at a critical point right now where I think the jig's up for the hospitals. It's up. We all know now that their unfettered power and self-governance has taken its toll on our society, has taken its toll on all of us. And dare I say, from the position I'm in, and I hope I don't get in trouble for saying it, it appears more and more to us that the administration, the people who are supposed to be protecting our public's health, are more and more complicit in this action of inaction, of letting the hospitals have their just more and more unfettered power with no check and balance system. And that's what we're up against right now in Leominster. So I'm going to put the big call out, the all call out, Chloe, because I can't walk away from this without seeing and exploring the value that you can bring personally to this fight right now. You know that the hospital industry is using your March of Dimes report to say that there are no deserts in Massachusetts. That's why we can close these units, versus what we just heard from you is, oh, dear Lord, don't close another unit because this is, and we're accustomed to that. We're accustomed to the machinations of the hospital industry and the narratives, then the constructs that they've created for us, because we're all so silly. We can't possibly understand the complicated healthcare system. What could you this is what's best for you, dear. And we've heard that as a profession in nurses, as of nurses who are predominantly women. That's a construct that we've worked in. We've seen this in our communities, the closures. One of the closures you didn't mention, or maybe I missed it, was mental health closures that are another of those that have happened all over the state. And when we look at the populations and the actual motives for why this is happening, it doesn't even matter if the hospital industry lies. If they just make up, they can create their own data, they can create their own. In the case of Leominster Hospital, the first rationale for closure was they had an insurmountable nurse staffing problem, only to finally disclose that it was 4 nurses that we were talking about. And there was, in fact, no hiring problem. Tara can speak to this much more clearly than I. And then shortly after that, they hired 12 travel nurses to work through the contract until the unit closed. Then it was declining birth rates in the area. Well, the DPH report and other reports completely disputed that and blew their data out of the water. Then it was an obstetrical shortage. The lists go on and on. We've debunked every lie they've told. The fact of the matter is they just get to keep telling the lies until we do something about this construct that they are allowed to tell those lies. So I'm a basic kind of person. I say it plain when I say it, and Chloe, I can't imagine that we should, we should be we reference your reports in every single press release we have. We reference probably your name. I don't know, that's a little flippant, but I just think combined, our work together is going to be that much more powerful, and particularly right now here in Massachusetts, right now in this fight, we believe that we can save this maternity unit. We believe that there is enough pressure. I saw one of the Lemonster headlines was one of your headlines. We've drawn enough attention to the governor. She can make a decision to change this right now. It's her administration that is allowing this complicit, the state for the state to be complicit in this. There are enough legislators in pockets all over our community that we're ready to mobilize. It's just, and we have an ideal opportunity right now. So I wouldn't be any community organizer that should get out of bed in the morning if I didn't if I didn't use this opportunity that we have right now today.
Of course, yes. And please, feel free to reach out to me directly to maybe we can talk more offline about how we can work together, because this is something our government affairs team at the national level really, really cares about. And, as we've seen, our reports haven't necessarily indicated a need here locally until this one. And so I'm being given more of a green light to start being more of an active participant. And so please let me know what we can do to help.
All right,
and I will bring it back to government affairs
later.
Perfect.
And Chloe, I know in the, sort of as we were waiting for people to come in, you were saying about having the March of Dimes has people in the NICU, and that the cost of that is like $100,000 a year, and you struggle to get that funded. And, the thing that outrages me the most in all of this is the kind of money the hospital administration is pulling in on, taxpayer dollars. And the CEO of the hospital we're talking about here makes $2.7 million a year. Like a tenth of his salary could fund so much service in the NICU, so much needed vital services. It's just so unconscionable to me that this is okay in the world we're living in right now. And I can't even go there with the Roe versus Wade overturn and the just feeling like women are under attack, and women's health in particular is being managed at this level that doesn't involve the impacted people, is terrifying. Just the financials of all of this is just mind-blowing. I know also we have Kwame here who's at WIC, and that's another group that is really invested in the health of women and infants. And you referenced their work in looking at who's getting prenatal care. So I don't know if Kwame wants to jump in. We have people from Family Health Center here. So although we don't have a big audience today, we have an important audience of people that are really working on this and recognizing this is a justice issue. This is a disparity issue. This is a capitalism issue. And they, as Sandy mentioned, they use divide and conquer strategy big time with this, right? They're like, they won't know, the people in Worcester won't notice what we're doing in Lemonster, yet here it impacts them. And Lisa, hearing you speak to that was really powerful. Like, we need to keep coming together on this, because it's one at a time that they're attacking, but overall they're decimating services to our communities. Mm-hmm. Tara, go ahead.
Thank you. Go ahead, please.
I just wanted to say, Chloe, so the head of obstetrics at UMass, so she oversees us somehow. She's never been to our unit. But when she met with the legislators in the beginning of this, she literally said, if COVID taught us anything, you only need 3 prenatal appointments. That's it. That's all you need. And then she also said, if the baby is moving, everything's probably fine. So I just wanted you to see, like, this is what we're fighting against. So it's so interesting to hear your take on the prenatal care. And like, obviously as nurses, we understand the importance of it. But that's what we're up against right now. So it's just interesting that she can't put in the time and effort to do her own research. And she's just making these comments. That it's just, that's been something that's been bothering me through all of this. So I really appreciated hearing your prenatal portion of that.
Yeah, thank
and
you.
just to, I just want to collect, maybe just add a little bit to what Tara said. That was in a meeting with legislators that the head of the chair of obstetrics for the entire health system told legislators what they learned in COVID is only 3 in-person prenatal visits are really necessary, because really all we're looking for is a prenatal heartbeat. And if the baby's moving, everything's probably okay. And that was the rationale for this being okay to close this unit. So while we as nurses hear you, that look, telehealth is here to stay. We know it's here. We've got to embrace it. We've got to work with it. But unfortunately, what we're seeing with this, if I may, Lisa, Tara, anybody correct me, is we're seeing, we gave them an inch, so now they're taking yard. And now we're seeing this overhaul of replacing that actual hands-on work, that actual one-to-one with a screen or a monitor on a computer and a telephone line. And in this case, of course, in rural communities, people ought to have access to healthcare. But to say that it's okay that we close a maternity unit because there's telehealth services, so you can have that, there is no substitute for that. And that is something that I'm afraid we're seeing it happening all over the place. We're seeing ICU beds monitored from Kentucky. That's already happening. So
wow, that is something I have not ever encountered or met with the chair of obstetrics at UMass. I find that comment concerning, to say the least. I'll be diplomatic in my response here, but that definitely goes against what March of Dimes believes. It also, and forgive me if maybe she mentioned this in the rest of her talking, but it completely negates the mother. If all you're focusing on is a prenatal heartbeat, I'll give an anecdote quickly. I have a good friend who's due with her first baby in 2 weeks. She lives on the North Shore and she's coming into the city to give birth. And her OBGYN, I don't know who it is, told her if she's taken a yoga class before, there's no need for a childbirth class. Which struck a chord with me. And so when I hear that in conjunction with something like this, there is something going on then in that world that needs more attention. And I will definitely bring that back to the rest of my team, because I've heard those 2 things within the span of 5 days, and I am concerned hearing that. I also do want to call attention, I think Jamie put a question in the chat. Does your group do advocacy for pregnant mothers who use drugs? Yes, 1000% we do. In addition to all of our maternal mental health advocacy work, we're also advocating for, increased access to services for perinatal substance use. We also have professional education trainings for providers on topics that include stigma reduction specific to perinatal substance use. We just did one through the Boston Healthy Start Initiative. It was an open invitation to everyone in their network. We had more than 40 people from all types of hospitals and community health centers come, all types of professions, so not just physicians and nurses, but also community advocates, lactation consultants, home visiting services, everything like that. And so I'm working right now as well to get those trainings into more institutions and more groups. Again, they require funding, but less funding than that NICU program. And so hopefully we'll be able to do more of that as well. And we've done advocacy work for specific policies in Massachusetts around perinatal substance use as well, and always monitoring for new legislation there as well. So yes, to answer in short, we very much do.
That's so great to hear, and such a great question, Jamie. I know that some of the child welfare system is is involved in this piece, and seeing that change is so important. We do not need all of these new kids in the child welfare system. That system is not succeeding as things are, and I'm just glad that there is an effort to change this sort of automatic signal to the child welfare system that you're not a fit parent if you've used drugs.
Yeah, I will drop our toolkit. The training that we offer really serves as an orientation to this toolkit, but it's free. It's called Beyond Labels. It was created in partnership with the CDC. It's a very good resource for providers. I would like it to be more readily available for folks to know more about it. So I've dropped that in there.
Link it too on our
yeah,
page.
perfect.
And we put your Massachusetts report, and we'll just continue any resources you want to send our way. We'll make sure people can
definitely. I'll drop an example of one of the print materials that we offer. We have a whole range of things, that we offer, but we also have these health action sheets on opioid use and things like that. And just to get the stigma out from it, make it more readily, conversed and things like that. The more available something as basic as this sheet is, the less afraid and anxious, hopefully, folks will be. So I know those are two small things, but hopefully, you guys find those helpful.
Kwame, if you wanted to jump in now, that would be great.
Yes, thank you. I wanted to add, so at WIC in the last maybe 4 or 5 years, we've pretty much made it easier for prenatal women to come in. They don't need to prove their pregnancy. They can come in and self-declare their pregnancy, and then we can begin the services if they qualify. And then afterwards, we can contact their medical provider to get the proof if it's needed. And then also, it doesn't matter. Unfortunately, some women lose the baby. So it doesn't matter how many miscarriages a woman has. She can come in anytime that she thinks she's pregnant. And then also in terms of a woman having a miscarriage, we continue the services for a couple of months after the loss of the baby, so as she can have a support system. And then also since COVID, we've kind of turned our nutrition counseling into more of a general counseling. So when women get on the phone to speak to a nutritionist, they are encouraged to lead the conversation instead of the nutritionist telling them what to do. So for example, I'm from Ghana and West Africa. We have a huge Ghanaian population in Worcester. And I clearly remember a mom about a year ago, hearing her tell me in my head, I was like, that's crazy. That's not what you called for. But then after speaking to my family, they're like, exactly what she did is what she called for. So instead of even talking about nutrition, she just wanted to talk about her immigration status for the whole hour. And the nutritionist kind of went to Google, found some lawyers' numbers, some agencies that could help her. And, because I'm a man, sometimes I don't think right when it comes to women's health, but I think that's where we are leading to. And then I'm going to take a break from WIC and kind of share like my personal side of it as a resident of Worcester. So I know in my African community, when I was growing up in Ghana, the most important person in my community was a pregnant woman, because we are a matrilineal society, and we also believe that you almost like never die, that if a woman gives birth, it's like a continuation of life. So moving from that kind of society to America, where I used to think, women's rights were top priority, and also having a daughter and seeing what's going on, one of the suggestions I have is for all of us to be a little more vocal, even in times of similar to what I did. So I was working about 2 minutes ago, and I took a break because my job don't allow me to say certain stuff. And one of the things that I noticed is even speaking to some of the families that I work with, they are very shocked with what's happening. One of the things that I've seeing people advocating in my particular community is actually calling elected officials and sharing their personal stories. So if you're ever interested in having people from the Ghanaian community or even people associated with it to share their story of childbearing and, you know, how it went for them, I'm willing to reach out to people. And then also coming back to work. So I'm coming back to work as a WIC representative. One of the things that we've been doing is especially women who are who don't have housing and are living in shelters, we sometimes make exceptions to make it easier for them in terms of the food packages that we give out. And then also even in terms of the documentation that we require. We realize at the WIC program that sometimes it can hinder people from seeking early help. So we've also instituted a situation where, for example, with the Haitian families who moved into Worcester recently, we actually went into the hotels to do the appointments instead of requiring them to come into the office, because we realized asking a new resident to take a bus is not ideal. And then also one of the things we've done with the WIC program is most of our documentation have been translated into like Haitian Creole, Albanian, Russian. Even the app that we have for shopping have different languages on it. So if you have any clients who have WIC, please always encourage them to upload the app. That's their best bet to maybe get the information in their own language, and also to help them in their shopping experience as well. Thank you.
Thank you so much.
So much, Kwame. I know you're always doing anything you can to increase access and improve access. And as long as I've known you, I've been amazed at how much you'll be flexible, you'll make it work, and just that attitude of we want people to get the services and their needs met. And Chloe, it was great to hear that March of Dimes advocated for people that aren't citizens to be able to get their health needs met. It's so important. And I see we have another, I don't want to mispronounce your name, but Gontron, please jump on in.
Yeah, I'm with my team over here at Family Health Center of Worcester. We're in the primary care psychiatry room, and then my director, Dr. Howard Young, is here, and he can't use his laptop, so he's using mine instead. You can turn on the video.
We're so glad you're here. Thank you.
Absolutely. Yeah, we're all using Nan's laptop basically at the moment. There's 7 of us here in the room. As Nan said, we have two of us are trained as family physicians who do a lot of psychiatry. We have a nurse practitioner who does psychiatry work as well. We have a pediatrician, and then 3 of our psychiatric clinical coordinators that are here in the room with us today, eating some delicious tacos while we listen to the presentation and the conversation. And basically, we just wanted to introduce ourselves and also just sort of, add a little bit to this conversation that has been happening here today. And I think, one of the things that we are thinking about a lot at the moment is the amount of mental health that is not taken care of around the peripartum period. And, for many clinicians and for the lay public, I think there's like this understanding that postpartum depression is a concern that we need to pay attention to. But the mental health needs of people who become pregnant are much broader than just postpartum depression, right? People come into pregnancy with all sorts of conditions already. And then during pregnancy, there's a significant risk of people developing depression in the postpartum period. We know that postpartum depression, yes, is the most common postpartum complication of any kind. And suicide is one of the leading causes of death in the postpartum period. But anxiety isn't that far behind depression. Postpartum obsessive compulsive disorder isn't that far behind that. Substance use disorders, and then, to go to the sort of headline of this talk, in some ways, trauma disorders are incredibly potent in our experience, both for the 2 of us who have trained as family physicians who've delivered a lot of babies and been in the labor and delivery setting at UMass, actually, and have our own, sort of war stories to tell about that. We see a tremendous amount of psychological trauma that happens in those settings. It's supposed to be, the most fulfilling, wonderful time of a person's life, this beautiful momentous moment. And sometimes it is, and sometimes it's that and a lot of trauma, and sometimes it's just overwhelming trauma. And people end up, if they have pre-existing trauma that they bring into pregnancy, that can add to the situation, and that can certainly affect both the parent and the baby, the fetus, and their lifelong health. And then the birth experience itself, oftentimes when you're in a situation where, at UMass, we call it a code white, where suddenly things seem like they're taking a turn for the worse, and, you're rushing someone to an emergency C-section, or, you're doing, interventions to try to get a baby out who may be stuck, or, something is going seriously wrong. There's the patient that is having a hemorrhage and losing a lot of blood. There's all sorts of sort of crises that happen, because childbirth honestly can be quite dangerous, as we know. And those experiences have tremendous effects on the mental well-being of the people who are involved in them, especially because oftentimes there's a lot of people yelling. No one's explaining what's going on to you. There's a lot of uncertainty about what's happening. People feel like they are in imminent danger of dying, or that their child is in imminent danger of dying. And that is a recipe for post-traumatic stress, right? And so people end up with that, sort of situation. And for us at Family Health Center, we serve a lot of patients who speak languages other than English as their primary language. And so imagine all of that added on top of not being able to understand what's going on because you don't speak the same language as the people who are providing you care, right? And then if we don't take the time to really talk those things through and to work that through, and all they get is an appointment 6 weeks later with a depression screening, we miss a lot of this, and it can have devastating effects on people's lives when it's not addressed. So we just wanted to introduce ourselves and sort of add to the conversation a little bit. I don't know if any of the other members of my team we might raise our hand again if someone else wants to say something, but I just wanted to add a little bit of that.
So important and so helpful. And that's one of the reasons why Worcester Addresses Childhood Trauma is here today. We recognize that things that happen before you're born impact you, right? Like maternal stress impacts babies. We have this information now. This can lead to generational trauma. And of course, as Jordan was saying, like if people have experienced any sort of sexual abuse or sexual assault, all of that is going to be right on the surface when they're giving birth, when they're having child, all of the things. It's so connected. And, mental health in general is something we don't take nearly as seriously as we need to. It leads to death just as certainly as any sort of physical conditions, yet we treat it like it's, an add-on, not a thing. So it's really gratifying to know that people are paying attention to this and are trying to attend to giving people a much better experience. Not only a better experience, but like this is a time when we could be catching mental health needs, right? We could be catching trauma as we're doing these screenings and get people the help they need. And that's going to have better outcomes for their children. So it's just such an important connection to make. And the industries cut these into all these smaller pieces so that they can just gloss it over, but all of the things are connected. And I'm glad that people are seeing this and coming together to make that case of how connected these things are.
Absolutely. I'll do another quick March of Dimes plug for our trainings. We've got another training. It's called Maternal Mental Health. It's not just postpartum and it's not just depression. We're trying to get that very foundational course into hospitals outside of labor and delivery, into NICUs, into OT, into anyone who encounters moms before, during, or after pregnancy. We just gave a presentation to Newton Wellesley Hospital because unfortunately they just lost Ariana Sutton while her twins were in the NICU. And I was really pleased to see folks from not just labor and delivery and the NICU, but also psychiatry and also occupational therapy and a few other specialties as well. And so my hope is to get that course out there to providers, across all facets, who half of their patients are going to be female. And many of those patients at some point in their life may become pregnant, may become moms. a few times over. And I just think that sort of understanding and knowing what to look for, and then knowing what to do when you suspect some kind of sign or symptom, should be a very rudimentary part of everyone's, you know, basic understanding of healthcare. And so again, I'm going to drop a file in the chat. It's our full course list. You know, there's courses on neonatal abstinence syndrome specifically. There's courses on easing parent trauma in the NICU. There's courses on stigma reduction. And so, you know, if those are of any interest, you know, please feel free to hand the flyer over to someone who makes decisions. You know, I'm happy to come in and bring these courses to life. You know, it's really, really important that folks have this understanding of mental health and substance use and all that before they're encountering patients with those conditions. And so yeah, I'll leave it at that.
Anyone can feel free to jump in if you wanted to add to the conversation or make any sort of points that haven't been made in regard to service access and who we're denying service to and how this is playing out. I know that the nurses in particular have really looked at the impact, not only on the workforce and on the population, just it's so much bigger than any of us.
About you know, because they're closing, they're trying to close Leominster Hospital.
Yeah,
it's like kind of a discussion about.
You're off mute. Are you talking to us?
Really? Yeah. I've seen their signs around all the.
Yeah. I don't know if that's just like the conversation or they're wanting to jump in. I'll mute them. But if you'd like to speak to this, please do.
Yes, I had one more information to share. So for foster parents of babies and infants, they automatically qualify for WIC without any proof of income. So if you're working with any foster parents who are taking care of babies and infants, they are more than welcome to apply for WIC, where we can provide formula for them and all the other food package. And then also for undocumented individuals, WIC is not a public charge. There's actually a benefit sometimes for undocumented people to be on WIC. So if they ever want to transition to get citizenship, we do provide a letter that gives them a discount on the citizenship application. And then most of the area lawyers in Central Mass and even the statewide, we've educated them on it. So sometimes it's difficult to talk to a client. So we always advise them to speak to their lawyer, and most of the lawyers will direct them back to us. Thank you.
Chloe, I don't know if you could speak maybe to, you know, doulas and midwives. And I know you kind of spoke to it for a minute there in a slide about that. And I don't myself have a good understanding of what the landscape is for those groups and how they may be increasing access, or if they're being, you know, sort of used as a tool to not provide access. But anything that you can share about that is, we did expect someone who had that expertise to be here today. So, you know, that's kind of missing, and maybe you can speak to that.
Yeah, sure. So I'll start by saying one of the main points of comparison we always look to when we're comparing the US to other kind of more developed nations is the proportion of midwives to both the population and to the number of obstetric providers. And so for a country like the United Kingdom, they have maintained a significant population of midwives into the 21st century. It never really fell. There are more midwives per capita than obstetric, you know, physicians. That's not the case here. You know, we went through a healthcare revolution and midwives were seen as old-fashioned. That's not really the case. I think a lot of other countries would beg to disagree. I am not an expert in midwives and doulas, but in talking to a lot of the midwives who practice in Massachusetts, I'm hearing, you know, two real glaring issues that is preventing them from growing. One is the lack of access to education. So there are 2 midwifery schools in all of New England. One of them is in Massachusetts. It's at Bay State out in Springfield. It graduates 6 students per class. 6. I mean, it's tiny. So you have individuals who want to become midwives, but there's only so many slots. So, you know, that availability of education is one glaring issue. The other one is insurance coverage, reimbursement for midwifery services. So, you know, there are major hospitals, Mass General, for example, with midwifery departments, you know, double-digit number of midwives practicing in that department. But if they perform a service, it's reimbursed, I think, 83 cents on the dollar to if a physician, performed the same exact service. So there was a bill last session to guarantee equal reimbursement for the same service. I don't believe it was refiled this session, but I know that's something that midwives across the country have been struggling with, is that hospitals are not incentivized to grow these departments or these programs because, again, they're not getting reimbursed at the same rate as physicians, and therefore they're less profitable. It does, unfortunately, a lot of the time come down to money. And so there are programs, there aren't enough programs. There are training, there are schools, but there aren't enough schools. And so that's kind of where we're struggling with midwives. Massachusetts only allows one licensure of midwives, certified nurse midwives. March of Dimes advocates for both certified nurse midwives and certified professional midwives, so 2 licensures across the country. And then with regards to doulas, there's no guaranteed insurance coverage, you know, in Massachusetts for doula services. The average cost of a doula is somewhere between $2,000 to $5,000, which for some people doesn't seem like a lot of money, and for some is a vast amount of money for something that is seen as, you know, a perk as opposed to a necessary service. And so guaranteeing Medicaid coverage for doula services is a bill that March of Dimes is advocating for across the country. It has passed in some states already. It has not passed in Massachusetts, but Mass Health, outside of the legislature, is developing their own initiative to reimburse doulas through a program that they will create and oversee. And so they've been having listening sessions all year to hear from the doulas as to what, you know, a successful program would look like in terms of, you know, it being accessible for doulas to meet competencies in order to qualify for insurance coverage, and that it would also be, you know, financially sound for the doulas, for it to actually, you know, make it so that they can continue doing this work full time. And so those listening sessions are still ongoing. There's going to be a hearing at the end of August from Mass Health and Health and Human Services. That's a public hearing for doulas and other professionals to testify in, you know, in support of the program or call out issues with the program. And so I can also send that to you, Amy, as well, if folks are interested in doing more doula advocacy. But right now, doulas are very much considered a bonus, you know, a nice thing to have, but they're not being reimbursed. But they're a very passionate group of advocates. I will say that they have really hit the ground running with this work.
Looks like Nan has another question from the Family Health Center.
You can turn on the video. No, I don't need to. Sorry, I just wasn't sure if we had if we were unmuted, but I'm Stephanie. I'm also here with Non. I am currently doing the care psychiatry fellowship here, and actually perinatal mental health and problems around birth trauma are some of my areas of focus. So thank you for holding this. I just kind of wanted to add to the doula and midwife conversation. And I'm not sure if there's issues in both realms of us having sort of less of them, but at our health clinic in particular, and I wish I knew more of the specifics, but I think there's a grant that allows us to have doulas for our patients. And we are a federally health qualified clinic. And so, you know, it's a service that our doulas can speak the language of our patients, which is great. And a doula's role is really to emotionally support patients through the birth process and through birthing, whereas, you know, the midwife has more hands-on, I think, sort of interactions with patients. And so I wonder, you know, I guess I'm curious to see if there are maybe more resources that different, maybe either like primary care centers or places that are providing prenatal care, like have to sort of access, where they could sort of provide these doula services for their patients as well, in order for that sort of birthing and laboring process not to be so lonely as it can be, particularly when you don't speak the language of your clinicians around you. And the other thing I think I sort of wanted to add, just from earlier in the conversation about 3 appointments being enough, you know, and how a lot of the time we're focusing on this after birth sort of depression. And I think we know that a lot of previous traumas from previous births can come with a patient into their perinatal journey, and actually seeing them more frequently during their pregnancy is a great way of screening and finding traumas and different things that we can address in order to prevent depression in the postpartum period, or prevent situations like postpartum psychosis that can happen sort of in the setting of, you know, we know that when you have bipolar disorder, you might be more sort of, more predisposed to getting postpartum psychosis, but also trauma is a huge reason why you could have it. And we actually had a patient that happened to, and it was in the setting of repeated trauma from past birth trauma that we hadn't been able to really, you know, get to the bottom of, so to speak. And so I think it's so important when we're thinking of birth trauma and of these issues to think about the intersectionality of our patients, you know, whether they are cisgendered, or whether they are speaking a different language, or whether they have a different culture, and sort of how that comes into play. And being very mindful of statements we make of like, oh, we saw, you know, for example, again, I don't know who, or I'd never heard the statement of, you know, 3 appointments are enough, but I think it's important to understand that there's so much intersectionality and so many different roles that our patients have in their life that affect their care, both physically and mentally, and particularly in the perinatal period that is so vulnerable. And it's, I think, you know, for those of us that are seeing sort of what our patients are going through, but also as providers seeing the paucity of resources and providers available to see the patients, kind of figuring out what resources we can get for them, and also how to educate everyone who comes in contact with them about the kind of things that are going on, or what resources are available to them.
Mm-hmm. Yeah. Oh, Sandy.
I just want to thank Stephanie. Thank you so much for that, because that just rang so true for me. And, you know, I want to be clear when I said that the comment about 3 prenatal visits. I don't think there's anyone who knows of a pregnant woman who's ever had a baby, who ever could think that 3 in-person prenatal visits is sufficient. I think what I'm hearing repeatedly is that we're a society of people that are at the mercy of the people that control the resources that we have access to. The thought that how little care and concern is actually given to what what Family Health Center is actually doing to help raise our community and grow our community, and with and what nurses are trying to do every single day, and what Kwame's trying to do every single day, and we're all fighting for the same little scraps. That is just so unjust. Amy, you said it early on. This is a matter of justice. The pure heart, that the work that's done at the Family Health Center and the Edward M. Kennedy Center that is vital for this community health link that just got closed down, that we're at the mercy. Collectively, I right now, I just feel so grateful that there are so many of us saying the same thing right now, and that we can unite and work to do something about this. That's a call. That's a call to the Family Health Center friends. I'm going to put my number in the chat. So if there's work that we can be doing together in Worcester, I would love to be. I'd love to talk with you guys over there.
Oh, that made me think too, what people have been saying. I know you've worked on some campaigns. So, obviously all of us want different outcomes. We want more resources. We want things to be better. But I know the March of Dimes has taken on, like, if you don't have access to care, and you have high blood pressure already, or some of the more preventative measures that people could take, knowing that they're on their own to a much greater extent than we'd ever want them to be. But with that as a reality, what kinds of things can we encourage pregnant people and their families and those who care about them to be doing to ensure better outcomes for themselves?
Yeah, definitely. The first thing that comes to mind immediately is a program called Count the Kicks, which Mass DPH just launched. It's a free app, free print materials, and it's very basic. It teaches pregnant individuals to count the kicks of their baby and to get familiar with how much their baby is moving. And it's primarily stillbirth prevention, but it's more than that, because we know that the activity and movement of the fetus can also indicate poor maternal health outcomes if something changes. And so it's also preventative in that way. And so that's an organization that I've talked to a few times. I've met with a few of their Massachusetts ambassador families. They're super fantastic. And it's really basic. And so that's the first thing that comes to mind. And then I know there are other March of Dimes teams in other states working with both primary care and hospital level physicians to distribute blood pressure monitors for patients to get familiar with measuring their blood pressure at home, and really just taking control and ownership as to how their body is doing, getting familiar with their body, being more in tune with it, because nobody knows your body better than you. Those are the two things that come to mind immediately. That's not to say there's definitely more out there, but I would very much encourage, I'll drop the website in the chat, to look at Count the Kicks, because I think it's about as simple as it gets. It's free. And DPH is going to be distributing it much more broadly statewide soon. Not entirely sure what the details of their campaign will look like, but it did just launch, I think, a month ago or so.
Yeah, sorry. I also wanted to add, here at Family Health Center, I believe it's state funded or grant funded. We do have we called it the Baby Cafe, which is basically breastfeeding education. And there's actually drop-in times. They're accessible in, I believe, Spanish and English, and I think interpreters can be brought in if necessary. They also have one day a week where they do a third trimester course, which talks about like preparing for that, which can be helpful for a lot of expecting parents as they're starting to prepare and are feeling somewhat alone in this, as you were saying, Amy. I also think they were happy. there's a mindfulness birth course that they were doing here too. I'm not sure if that was open to non-family health center patients like the breastfeeding courses, but if anyone here thinks it would be helpful to have the flyers, we can put them in the chat.
One thing I will also mention on kind of going back to the subject of doulas, I'm not positive if this is included in the Mass Health developed program, but the bill in the legislature, part of that bill, it would create a statewide registry of doulas so that healthcare providers would be able to find doulas to suggest or recommend to their patients, or at least have a service available for patients to look on their own, because there isn't really one place you can go to find all of the doulas in your area. Most of them are private practice. There are some hospitals with programs. Boston Medical Center has a doula program. Mass General has a doula program, although you're not paired until your third trimester. So you don't get as much time to get to know your doula, which is one of the most important parts of it. But there are a few hospitals doing programs like that in the meantime. But hopefully at some point there will be a statewide registry available.
That sounds like it'll be really helpful. Are there, oh, go ahead, Tara.
So one thing, I think it's been like talked about a little bit, but one thing about trauma, so since they announced the closure, we've all been like saying like babies are going to be born in emergency rooms, they're going to be born in ambulances, they're going to be born in cars. So for some reason, over the past like month, this has happened multiple times. The last 4 shifts I've worked, it's happened where babies are born in the car, just coming to Leominster, let alone having to go to Worcester. Babies are born in the emergency room. And I've been part of 2 code whites in the emergency room. And it is traumatic for me as the nurse to see the chaos. I mean, I think this was used as an example before, but like you could be giving birth in the emergency room and there's a prisoner next door. That literally is happening. There's so much going on. So, and then there's just every single nurse, there's only 1 to 2 doctors on. They're all in this room. Nobody knows what's going on. We don't have the correct equipment, so it's me and the pediatrician at one of them, and we're calling up to our unit to get things brought down. And then there's the mom who's just like lost in this. She's watching us do this to her baby. Nobody has a clue what's going on. We don't have the correct tools. And then, for instance, like the mom I felt like no one really paid attention to the mom, and she ended up getting really sick in one of the incidences. And it was just something to me that I'm like, that's not going to be the only time this happens. The fact that it happened before the closure was telling, because if she would have had to drive to Worcester, or had she been driving to Leominster and it happened, the pediatrician wouldn't have been there, the obstetrician wouldn't have been there. So I can't even imagine how much worse the outcome would have been. But I just think that trauma is going to be so prevalent in and of itself, because I can't imagine someone would want to have another baby after that. I can't imagine her postpartum period is going to be very good. So I just wanted to shed light on that, because I know like people have said it, and like I've said it publicly, like babies will be born in ERs, babies will be born in cars, but it's like bad. Like I've seen it firsthand since the closure announcement, and I cannot believe like what is going to happen. And that's statewide, and across the country, but it's bad. And I don't think as a lay person anyone would like understand it unless you were in it. But my dentist had to have me buy mouth guards since the announcement of the closure, because I just constantly am grinding my teeth, stressing out. And I was in the ER and I'm like, thank God I just put gum in my mouth, because I was like, I'm just so upset they didn't have any of the tools. And the hospital has been saying like, we have what we need, we're going to train the staff. I'm like, you're not going to train the staff, you don't even know what you need. So I just wanted to throw that out there. That's just every night I go to work, 3 a.m. something happens. So I'm working tonight and I'm not looking forward to that. But just so you guys all know, like, it's already happening and it would continue to get worse.
Thank you for shedding light on that. And also, I'm really sorry that going to work has become such a stressful thing to think about. And I think that's another repercussion that no one is talking about enough is I don't even want to call it burnout. That seems to put the burden on the healthcare worker. The environment in which you're being forced to work in is, of course, going to cause stress and anxiety and exhaustion and trauma, PTSD, and that's not being talked about either. And I think that's hugely important. So thank you for sharing that. And thank you, as you said, for doing your own advocacy work and saying that in front of legislators. They need to hear this stuff. They're, it's very normal for a physician to come into the legislature. They're familiar with them. They have things that they've been working on for years and years and years. They're not as familiar with the rest of the hospital staff doing more of this work every day. And so the more that we can rally the troops, I think that hopefully the better the outcomes will be.
And Tara made that point earlier too, like the decision makers aren't interacting with impacted people. It's really easy to make these decisions when you never have to be face to face with a mom who's struggling, right? And so they get to make decisions and it falls on Tara and Sandy and like people that are really right there with people giving birth to sort of deal with the fallout. And the recognition that there is fallout. Like this is how you said that, like this mom is going to associate all these bad things with this newborn. And how is that going to play out and how she's taking care of that newborn? Of course, it's going to make a difference. We know now that things that happen to you in early childhood are hugely important. They have lifelong implications. It isn't, you're not going to remember, so you're not impacted. That is not the truth. And we need people to understand that this is important. We really need to resource early childhood, women, children, infants. And I'm just so glad that the advocacy focus and the people doing advocacy are here today. And if there are other I know, Chloe, the March of Dimes has ways for people to get involved. Are there other advocacy pieces that the nurses want to share, or anyone wants to say, besides calling our elected officials? And our elected officials are all on board with this. Fortunately, we have had beautiful results with working with our electeds on advocating, and they are working their butts off and still up against the wall. So any thoughts any of you might have to how we can better advocate for the needs of women and children in our region?
So say, go ahead, Sandy. You look like you're going to say something. No? I'd say one big thing is share on social media. I'd say the information that the March of Dimes shares, the information the Massachusetts Nurses Association shares, I think just sharing the stuff on social media also helps educating people. And then the more that they hear about it. I mean, I know it seems so simple, but I think that the more this has become, I look back 5 years ago when we were fighting the closure in Taunton, and we've come so far when it comes to, talking points and just general information and advocacy and connecting people to the facts and spreading it, right? I mean, I think that that's been the power of the Leominster campaign, is that so many people across the state are now following it. And then I think by following places like the March of Dimes, organizations like the March of Dimes or the Mass Nurses Association, that you can quickly respond when they say, hey, this is going on right now, or check out our website, or what have you.
I think March of Dimes has a social media kit, don't they? You guys,
We
social
do.
media.
We do. We have social media kits for different campaigns. Let me see if I can find that. I did just drop the links to our Boston or Massachusetts statewide Instagram, and then my personal LinkedIn. Please add me. I'm sharing stuff from March of Dimes and other partners all the time. I'm trying to get connected with as many folks from like Boston Globe and other folks to make sure that they see it as well.
Great. Any other thoughts or comments or questions before we call it a day on? And so much appreciation, obviously, for Chloe, especially Chloe. That's so grateful. I think we all feel much better equipped to speak to the issues. We have a better sense of, kind of how to use your work and how to use the reports. And it's been great how receptive and responsive you've been to our concerns that are unfolding as we speak. So I'm just super grateful for that. And yeah, if anybody wants to add or comment, please do.
I just want to thank you again, Amy, and I just want to acknowledge again how pervasive the trauma is. It's just pervasive. There is not, it's a trauma to the baby, it's a trauma to the mom, it's trauma to the caregivers, it's trauma to the advocates. It's pervasive trauma that is in this case, when we talk about shortage of access, all of the trends, everything shows that we need more. We need more. We need more doula services. We need culturally sensitive services. We need more units. We need more prenatal care. We need more bonding time. When I hear count the kicks, I hear, I bonded with my baby during that time. That was my time that I was acknowledging that. And if we're not talking about that and we're taking away every opportunity for education and advocacy, we all see it. We all see it. And I'm just so grateful for this program today, Amy, Trauma Training Tuesday, and Chloe and Kelsey. And I'm grateful for every single person who's doing this work right now. We're fighting there. All we want to do is take care of people. That's all we want to do. We want to make sure that everybody has what they have, and we're distracted with the bureaucracy and the politics and greed and powerlessness. And looking at faces today, having this conversation, I feel powerful. I feel more powerful for us to continue the work that we do, to just keep taking care of people.
And Cindy, the only way we win is when we all come together on this stuff. So the more we can say, like, WIC's interests and March of Dimes interests, nurses' interests are very aligned on this topic. So working together, our impacts can be doubled, tripled, and magnified. And that's what we need right now.
Yeah, I mean, it's complicated. Childbirth is complicated. Parenting is complicated. Look at that little monkey jumping on the bed right behind Tara. It's complicated. We need anchor institutions. We need to gather together to make sure that we're taking care of each other. And more we're left to fight fights and take care of each other with so much less than and it's entirely unnecessary. So I just appreciate everybody calling this out and giving us all the armor and artillery in my arsenal that I need to get out there and continue this fight.
Beautiful. Thank you all so much. We'll be putting up the recording as soon as we have it, along with all the resources you shared. We'll link on the page. We'll send you that on LinkedIn, Chloe, so you can get stuff out there too. And it sounds like there's so many other great programs that you have that I'm sure people will want to take advantage of. And, Tara's page, the Leave Labor in Leominster, has a big reach already. So if they can get more resources, we might actually win one. Wouldn't that be great for all of our morale, right? So thank you again. Thanks so much to everybody. Kelsey put a link in there for DPH funds us, and they like to get a little bit of feedback. So if you wouldn't mind, that would be great. And there's so many resources in here that we're gonna happily share along with our audience. And again, we're just grateful to all of you for doing this work and caring about people and their mental health and their children's mental health. Thanks again.
Thank you so much. This was truly wonderful. I feel so inspired right now.
Me too. Thank you. All right. Take care.
All right. Bye, everyone.
Friends.
Thank you.